Good afternoon. All right, so we're going to get started here. So welcome everybody to the neonatal breakout session. We're super excited today about this session because it's going to be awesome. So we're just going to situate ourselves here. Get up and down. All right, so what we'll do, we'll just quickly introduce ourselves. It seems like we have a lot of people, but we have so much to share with you, and we wanted to, discuss what we do in our centers and not just have a series of talks. So we're going to try something a little different. So I'm Natalie Rintoul. I'm from the Children's Hospital of Philadelphia, and my co-moderator is here all the way from Chile.
Thank you. Thank you, all of you. I'm coming from Chile, from Santiago, from a NICU and a pediatric unit that we take care of many of CDH cases and cardiac cases.
Thank you. Okay, and then Brian, we'll see if this is on. Should be.
There we go.
Yeah.
It's on now, yeah. I'm Brian Gray. I'm a pediatric surgeon from Indianapolis.
I'm John Daniel. I'm a cardiac neonatologist from Kansas City.
I'm Cheska Michela. I am a neonatologist at Arkansas Children's Hospital.
Hi, I'm Nick Carr. I'm a neonatologist over at Primary Children in the University of Utah.
Hey, I'm Kate Ryan. I'm a pediatric cardiac intensivist at Lucio Packard Children's Hospital, Stanford.
And I'm Bob DiGeronimo. I'm a neonatologist at Seattle Children's.
All right, so what was even more fun was preparing this. We met and we went through things and we just had a great time. And again, it was sort of like the CDH breakout. We realized that we're all doing things differently, like really differently, and learning from each other. So this is going to be great. So today we're going to focus on providing you with a nice update on the new VV dual lumen cannula. Dr. Gray is going to do this. And then there's a lot of talk about centrifugal pumps. So we're going to share stories from centers who are really, making it work. And then a lot of talk again about bival. So again, experience from centers who are really enjoying it. So that's what the hour is going to be like. Okay? So without further ado, we'll start with Dr. Gray.
Thank you. It's just a little clicker here, forward. Perfect. Oh, the green button, it's the big one. Great. Hey, everybody. This is the last session of Friday, and for those of you like me who have to leave early Saturday morning for soccer, this is the last session we'll be here at the conference. It's been a great conference, so thanks to everybody. Just one area of disclosure, I do serve as a consultant for training and education for this cannula for the folks at Medtronic. So I know a little bit about it, but they do give me some money to talk about it, but they're not giving me money to talk right now about it. So I'll be happy to talk very candidly. Neonatal VV cannula, and why do we care? So there, as we all know, pretty much those of us who have been around for more than a few years, know there are two historic neonatal VV cannula options. We had the Origin cannula made by Origin Biomedical, which came in the 13, 16, and 19 French for our infant patients, and the Avalon Elite cannula, which is a bicable design with drainage in the SVC and IVC, which was available and still is in the 13, 16, and 19 French sizes. Both had great acceptable support parameters, adequate flow, limited recirculation. However, there are definitely differences in design, the cannulation technique, and the risk profile to our patients. The Origin, unfortunately, has been unavailable since late in 2017. And the Avalon, with that, there's been some concerns about where the tip location sits, particularly in the neonates, because the neonates have such a short inferior vena cava, it's very easy for that cannula to flip up into the hepatic veins or to the right atrium or right ventricle. And then once it does that, it's really hard to replace it. If you were in some of the last talk by Dr. McMullen, you see some pictures of that. And then so with this difference in the cannula we have, it really made us reassess how we care for our neonatal respiratory patients. So here's a couple photos I have here of some graphs I put together of looking at the ELSO registry from 2000 to 2020. And you can see both in the US and international locations here for ELSO, we've seen a very steep drop-off in the use of VV ECMO for neonatal respiratory care, really starting in 2017 and 2018. And if you track this out actually to 2021, it even takes a steeper drop-off. So you can see that around the world, we've been doing a lot less VV neonatal respiratory care since that origin cannula has been unavailable. And I think that's because we have some centers that are Avalon centers and use it well and trust it, and there's some centers that really just didn't want to make that leap to Avalon because of some of the things we've heard about with the cannula and some of the risk profile. So fast forward to about a couple of years ago, the group at MC3 Cardiopulmonary in Dexter, Michigan, that's a former offshoot of University of Michigan ECMO lab, said, hey, we want to try to fill this void of having a right atrial cannula that can be used for neonatal and infant ECMO. And so along came the Crescent RA cannula. It was FDA approved for use in the United States last September, and now we have 13, 15, and 19 French cannulae. Lab testing showed excellent flow capabilities and really limited recirculation except at very high flows. And as I said, it was FDA approved. So here's what the cannula looks like. It's basically a smaller version of the larger Crescent cannula. And for a while, I didn't really know what Crescent means. And I don't show the picture here, but if you cut this cannula in half, which I wouldn't advise you to do because it's too expensive to cut in half, you'll see that the lumens are arranged in a crescent formation, and that allows you to get much better flow and reinfusion capabilities than some of the other cannulae. So it's kind of a shorter version, and what you see is that you have 3 different zones of the cannula. You have an SVC zone, we can see at the top here, that has a little tantalum radiopaque dot. It actually has 6 drainage holes in the SVC, looking at the next diagram. You have a right atrial zone, which has a little set of tantalum dots, which are a little triangle, and they're 2 stacked upon each other and one directly opposite to it. That zone's supposed to be in the right atrium. That actually has 4 drainage holes and 1 reinfusion hole. That reinfusion jet is made at an angle, so it will reinfuse blood directly toward the tricuspid valve and into the right ventricle. That allows you to keep the cannula potentially a little bit higher up in the atrium and potentially a little bit further away from the edge of the atrial wall and the IVC, so you maybe have a little less injury. And then additionally, there's another drainage hole at the very tip, and you see all these tantalum dots, which allow you to track your cannula position and your cannula rotation on X-ray. Again, as I mentioned, we want the cannula tip to be in the mid-right atrium to upper right atrium, as shown in this diagram. And then here's a photograph of a chest X-ray from one of my patients, and we can see the tip of the cannula was about in the middle of the right atrium. This was verified by echocardiograph, and we can see the 2 dots, they're stacked on top of each other, pointing towards the patient's right. And when you have that view, that means that the jet is going towards the tricuspid valve. And so how is the cannula doing? How are we doing with the use of this cannula? And that's something that we've been looking at through the CHNC, which is a Children's Hospital Neonatal Consortium group, which is a group of 34 level 4 NICUs across the country, and we have a subgroup that is all people interested in ECMO. So we said, well, let's pool our data over the last year of the use of this cannula and see just what we're doing and how we're using it. And so that's what we've done over the past year. We've had 12 participating centers and anywhere from 1 to 7 cannulations per center. I think CHOP has been the top user with 7 cannulations. 36 patients have been supported, and the vast majority have been with the 13 French cannula. And as I repeat, this is all neonatal patients, no older infants were used. The mean weight of our patients was 3.4 kilos, and we supported patients for a median of 110 hours on ECMO. Our survival at discharge in this group was 92%. And you can see we had a few patients that unfortunately died, one from the cannula directly, and I could talk to somebody about that later, but we did have 1 cannula perforation in our group, unfortunately. Cannulation itself was 83% done by an open cut-down technique. A nice part about this cannula is you can do it open cut-down technique or percutaneously. And there was a really vast difference in what people use for imaging guidance during cannulation. About 40% of the centers use some sort of multiple modality technique using either echo, fluoro, X-ray, or a combination. 42% use at least echo, 19% use at least fluoroscopy, and 25% use none. And these were on open cannulations. And then after the cannula is placed, every center used echo and chest X-ray to verify the placement. Unfortunately, there were some complications. So there was one major vascular complication with the perforation where the cannula slid in a little bit and the patient's anatomy changed somewhat after the lungs lost their aeration, and we had 1 perforation. We had positioning issues in about half of the patients, and that required surgical repositioning in about 1/3 of the patients. Additionally, there were 2 patients who had recirculation. So I have a poster outside. We can show different positioning of where the cannula might be ideal and not so ideal. So on the left image, you can see ideal positioning of this cannula, although you can see the patient's head is actually to the left-hand side. And this is where I found this patient to have the best positioning with the cannula. The middle one shows unclear positioning because the lungs have dropped. So I really can't tell where that patient's heart is. I can't tell where the diaphragm is. So it may be in an unsafe position, even though the tip is at about the same spot. So I would get an echo on this patient to verify. And then the third picture shows a cannula that is clearly too deep and needs to be repositioned. And then here's a picture I borrowed from our friends in Atlanta where they show actually a patient who had pretty high recirculation because they were using a cephalic drain. So you can see on the right, it's dark blood from the cephalic drain. On the left is the reinfused blood and recirculated blood. And they found that this was because the cannula tip had gone a little too high. So the reinfusion port was in the SVC. They advanced the cannula and they got good support after that. So our recommendations with this cannula are that for imaging during placement, we want to use something, either fluoroscopy, echocardiogram, or chest X-ray. If we're doing a percutaneous cannulation, I advise people to use fluoro and echo if at all possible, and then we want to verify with echo and chest X-ray. And then the key for this cannula, I think, is really daily maintenance. So you want to get a daily chest X-ray. Sometimes I do two times a day chest X-ray. I want to get an echocardiogram once a day for the first few days to make sure my position is good. And then I have a really low threshold for getting an echo during our runs with the patient. If anything's not right, we get an echo, either by having our echo techs come in or doing a point-of-care ultrasound. And then I try to maintain the patient in a pretty sedated spot so that they're not moving around. And that's my sort of update on the new VV cannula. We'll take some questions or discussion later if anybody has that. All right, thanks.
Yeah, and so we'll maybe wait for questions until the end if everybody's okay with that. So now we're going to switch and we're going to talk about centrifugal pumps. And, you know, we feel like this is a really important thing to talk as a neonatal group. Years ago, we talked about a high risk of hemolysis, and many of us went back to roller pumps for the kids who are less than 10 kilos. And then, you know, we have papers. This is the most recent publication, 2019, PETA and her group, you know, showing that centrifugal pumps have increased mortality and complications. And so this is really the last big paper published. But yet we know that we have colleagues around the country who are moving to centrifugal pumps and saying that they're not having any troubles. So what we wanted to do in this session is really kind of, you know, break this open a little bit and talk more specifically. What are those centers doing now that is different than it was before? So that's what we're going to do. We're going to do this in kind of a different way. We got this listed. So these are the groups that are using it and having it work. And so what we thought we would do is just sort of go around the table and say a little bit at each center what's working.
Okay. I can't figure out the microphone. So I'm from Arkansas, and we use a centrifugal pump, and we have not had significant issues with hemolysis. And you can read there, we use the Spectrum and the Mackay Rotoflow. PFH goals are less than 20, and we do use a bladder with a 1/4-inch circuit.
I'm over at University of Utah, and we are also on a Rotoflow system, so we are centrifugal across the board. We have had ongoing intermittent issues with hemolysis with the centrifugal system, but once we transitioned to primary BiBAL about a little over a year ago, we've actually seen some improvement in our hemolysis conditions that we've had. And plasma freeze less than 30, and then again, no bladder.
We haven't really used it aside from transport, so that's not helpful.
I'm Bob DiGeronimo again from Seattle, and we use the CardioHelp on all of our babies, both in the NICU and the SICU. And I would say we have a little bit of hemolysis. Probably 80% of the runs are fine. We have a patient here or there that we do run into some issues with hemolysis. And I think, as people know, it's a multifactorial problem. But for the most part, it works pretty well for our center using a centrifugal pump.
So I'm John Daniel from Kansas City. And we had about a 3-year period where we switched to a centrifugal pump, and then we switched back. If you say the word centrifugal pump to my partners, they tend to have a PTSD reaction to it. So we've stayed with the roller with a caveat in that if we're going out on an ECMO transport, we will send the CardioHelp system out, and we will use that. You know, we are out in kind of the middle of the country, so you know, if we're going from Kansas City to western Kansas, it's kind of a hike. And so they have, you know, kids have been on it for several hours before they get to us, and then we'll get converted to a roller system, and I've not seen a whole lot of hemolysis with it. You know, the older system that we were using, really just, you would see high plasma freeze, you know, in the hundreds. They'd get this terrible rash, and then they'd get really hypotensive, and you couldn't rescue them. And so there was a period there where my partners were just terrified to put anybody on ECMO. But that doesn't seem to be what my colleagues up here who are using centrifugals now are seeing.
Yeah, and there's a slide with a poster, but when we polled the CHNC group, of the 20-something centers, I think the slight majority use centrifugal pumps. Maybe we could ask the audience, how many people actually use centrifugal pumps in neonates? Good.
Oh, wow.
How about roller pumps? Yeah. Interesting.
Does anybody have any centrifugal questions for the panel? Sorry, you'll have to wait. Yeah. Dr. Bartlett comes first.
Natalie, you did not warn us.
No, this is a great discussion. I'm just stand up to tell you something that I'm sure you already know. How do centrifugal pumps cause hemolysis, and why did that suddenly happen when we went from roller pumps across the board to centrifugal pumps? It was a good reason to go to centrifugal pumps because they can't blow out. Yeah. And any of you been in this business longer than a few years, you've had a roller pump blow out. It ain't fun. So it was a good thing to do. But centrifugal pumps cause more hemolysis, especially in babies, because all the geometry is so much smaller. So the way that a centrifugal pump causes hemolysis is by cavitation. It sucks the oxygen and nitrogen CO2 out of the red cells, and they break in the process. So that has to get to about minus 650, almost minus 700 for that to happen. And so it rarely happens, but it can, because you're draining, and you say you have a negative pressure of 30, fine, 100, fine, 200, fine, no problem with that, 250. Everyone kind of has their limit. This is too much suction, but that doesn't cause hemolysis. What happens if you're running along at minus 100 and suddenly there's no venous drainage, just for 2 seconds, baby turns this way or that, somebody steps on the line, who knows what happened, and that pump is going around at 4,000 RPM. So the negative pressure, if you measure it on the line, might go to minus 300 or 400, but in the middle of that pump, it goes to minus 700. And you can all see this if you haven't seen it already. You see the chattering and the venous line, and little bubbles occur. They're in the pump, that's where they are, but all those bubbles came out of red cells that broke, that went in the process. And then you quickly solve the problem, it goes back on, and there's a lot of free hemoglobin. Also, those little bubbles go back into the baby, but they're mostly oxygen, so they get dissolved, doesn't cause a problem. So just so you're aware that's why it happened. Now, there's not a lot you can do about it except to be very sensitive to the fact that if you're having chattering, and you know, for 1 second there's no flow on the venous side, it's going to cause hemolysis every time. So just to understand it makes it a lot easier to try to deal with it.
No, that's awesome. And some centers have said they run the hemoglobin a little lower. Just before you sit down.
Okay,
What do you
now
think
you
of
got
that?
my attention. You're all pediatricians. You understand about hemoglobin and oxygen delivery. So it is true. A few centers that ran the hemoglobin high had more hemolysis for exactly the same reason. They're just more red cells there. But don't lower the hemoglobin just because of hemolysis. Figure out how to not cause hemolysis.
Thank you.
Hello, my name is Kirillo. I'm from Vancouver Children's Hospital, Canada. And I was wondering if it's more like a comment. What we do, because we're using CentriMac for all up to 15, up to 20 kilogram patients, successfully without any hemolysis at all. But we all have bridge in our circuit. And we always run the flow through the bridge of between 200 to 500 mils, regardless of the patient size. So even if there is any clinical venous return concerns, which was just described nicely, happen, there is still half-liter flow through the pump head, preventing that sort of excessive negative pressure, things like that. Also, the other source of hemolysis is actually friction inside the pump head. There are multiple studies showing, especially those which are not levitronics and having a point of contact at the bottom, where the temperature generates and stasis happens and all of that. The levitronics levitating pump head, not touching the walls at all, and also for whatever the amount RPMs, 3,000, 3,500, there is still above half-liter of flow through the pump head, which prevents the stasis in the pump inside. And we have a threshold of 50 for the free hemoglobin, and very rarely, only when we have thrombosis and clots in the circuit elsewhere, that's where we will see the free plasma hemoglobin. But related to the pump, in 6 years, I haven't seen a single. On average, we have 15 to 20 cases a year. Thank you.
Thank you. Any comments?
Yeah, I think that's a great point. You know, a lot of it is, we didn't really plan to get too much into different manufactured pumps that are out there, but I think it does make a difference what system you use, and also, as you point out, your circuit design and how you manage ECMO is important.
Definitely.
Mike Kropsky, Primary Children's Hospital. I have a question for Bob. The cardio help in neonates, do you have problems maintaining the integrity of your oxygenator? And by building a shunt into the circuit, do you think that contributes to higher plasma-free hemoglobins?
So we do have a built-in shunt off of the oxygenator. So we do runs kind of similar, that it provides about another 300 of flow or so. So the oxygenator still sees, a higher amount of flow. And we use the adult oxygenator. We don't use the PD one. But I think that's a little bit part of it, but I think by having the shunt in line and using the adult oxygenator, we haven't had. It seems like a lot of our problems, it depends a little bit on the patient. I think, as Dr. Bartlett said, the smaller diameter, when you have higher resistance, where the cannula sits, and also what the underlying physiology of why the patient went on ECMO, all those things seem to contribute. But I do know when we switched actually to the cardio help from the other system we were using, our hemolysis got actually much better than it was when I first got to Seattle. So.
Thank you.
Hi, Rachel Chapman from Children's Los Angeles. The one other thing, we have also changed systems and have much less issues with hemolysis. But my question and one worry, particularly in some of the older case series, is whether there may also be a higher incidence of hemorrhage, of intracranial hemorrhage in the smaller babies. And the thing that we worry about a lot is because you're not setting a flow, you're setting RPMs and your flows are variable, whether particularly in the HIE babies or the late preterm babies, whether that may, physiologically it makes sense that we may be altering or not having as much control over the cerebral blood flow. And in kids who already have very dysregulated cerebral blood flow, whether that may be an additional problem. Just to throw it out there, I don't know if other people have worried about that or thought about that. But.
Any comments from the panel?
No, I think everybody's hit the nail on the head here. It's probably multifactorial across the board. Your patient is equally responsible, so we can blame the babies on it, but as much as we want to talk about the pump and the circuit, it really comes down to the dynamic management and trying to minimize things coming off the road. And so to Dr. Bartlett's point, if you can minimize interruptions in the circuit, any issues with the pump dysfunction, but also optimize your patient management, especially on the spectrum of premature to CDH to surgical to all the things that go into it. I think it's really, that's the reason why we're all here, is how you get that little extra piece to keep that in line.
As far as head bleeds, we did actually look at our CH&C experience with that, and we found a lower incidence of head bleeds with VV versus VA. So I do think that you worry a lot about autoregulation in that population with reperfusion injuries. So yeah, I think that's just something to keep in mind with those patients.
All right, another question?
Joanne Starr from Chalk, Orange County. I've got two questions, or one comment and one question. We actually started looking at plasma-free hemoglobins before we go on ECMO. And we don't always get them because sometimes there's just no time and we just can't get the blood, but we just started doing that. The second comment question I have is, I see a list of PFH goals. I'm curious in the group, when do you change your circuit when you don't meet that goal, or do you just go by the clinical picture? Because I think there are two types of hemolysis. There's hemolysis by the number, and then there's hemolysis clinically, where you have, really gross hematuria, you're having, problems with your platelets, a hemoglobin, et cetera, and then you really have to change the circuit. And then miraculously, it gets better. So we have a higher incidence in some of the small babies, and I think some of it was related to changes in pump flows, where there were a lot of people changing the flow. And when the flow was more consistent, we had less hemolysis, and that was something that we did notice. And it varied unit to unit.
And then I'm curious to know if you've seen anything checking the plasma-free before going on. It
depends on the patient, and this is all anecdotal because we really haven't gone back and we're a medium-sized program. We noticed that some of the really sick neonatal babies, CDH or sepsis, will have a higher plasma-free hemoglobin before they go on. And again, totally anecdotal, as opposed to the older kids, which, most of their plasma-free hemoglobins are on the lower side. But to be continued. But I think it's worth doing if you have the time and can do it.
Any comments about the? Yeah.
Some of you do that?
Yeah, we try to check it also, and I think that's exactly right. Where that's certainly part of it is the patient, and we do see patients right. The first plasma-free you check, it's already elevated before you've even done anything ECMO-wise. So there are other things that induce hemolysis, and I think to your point about I think that it's a number for a target, but at least for the places I've been, our threshold to intervene, if the baby's doing okay, we'll live with a higher value and not necessarily change the circuit if we're not having those other complications, and try to do what we can to address the hemolysis. But it's more, as you stated, when you start having complications related to hemolysis, then we'll change it.
I would just piggyback what you said. We recently had a neonatal case that the circuit looked clean, but the plasma-free was way elevated. This baby ended up having an isoimmunization component from that standpoint. And our coordinator out there was like, I'm not changing the circuit looks great, and I'm not doing this for this plasma-free. And we're like, well, we see hematuria, we see all this plasma, and then you keep going back into it. Ultimately, we still convinced him to change it, and it didn't fix it. And so it's one of those things where I agree, it is a number, and you have to look at that constellation and have a good communication about it, because if the circuit looks great, then you have to remember patient-related factors as well.
I'd say we do the same thing, and I'm looking at Blake, who's our coordinator sitting here, and oftentimes I'm like, Blake, this number doesn't look good. Are we changing? He's like, no, the circuit is fine. And other times, the number may not be as high as it was in another patient, but he's like, we need to change the circuit, the patient is deteriorating, or look at the circuit. So it's not, you have to put both of them together and really have great communication with the team.
In other words, look at the patient, look at the circuit, and look at the whole picture.
Yeah, absolutely. Well said.
Dr. Deria from Houston, Texas Children's. I have a comment. First of all, I work in the lab, and the methodology to measure plasma free is not the same. So our lab has a normal range of less than 30. So our previous method was less than 5. So that's one thing. And the second thing is there's an interfering substance, which is lipid. So when a patient has a high triglyceride, it's falsely high. So, and the newborns may not receive propofol, but the propofol is a lipid. So that really increases the value. So you have to be very careful. And it was said that it has to be confirmed by hemoglobinuria, not a hematuria. So it should not have red cells. So if a plasma free is high, we have to confirm that it's a truly high value.
Yeah, that's very important. Thank you.
Laura Hollinger, I'm a peds surgeon in Charleston.
Hi.
Question, are we all talking about neonatal respiratory, or are we all talking about congenital heart and neonatal respiratory and PICU? I guess I'm just trying to clarify, like, in programs that have switched to centrifugal pumps, do you apply that uniformly to your program? In my program, we have such a wide variety of patients and needs, adult and peds, and so when thinking about purchasing new pumps and keeping up and that type of thing, it becomes quite complicated when the patient variety is so wide. And I'm just curious if any congenital heart programs are using centrifugal pumps in their patient population, or if we're just speaking about respiratory.
Anyone?
I can talk to that a little bit, since I do take care of the congenital heart population. If they're less than 10 kilos is still kind of our cutoff for all patients, other than the ones that we do on transport. But I don't know if...
I mean, we've gone down to 8 kilos when we've needed to with a centrifugal pump with our cardiac patients, and we've started, if it just depends on pump availability, but our practice within our center is to still use the roller head for the smaller kids. But in our institution, at least, whether it's VA or VV, I don't see that would be a difference for us.
Our SICU uses the centrifugal pumps, even on the smaller babies.
I will add one other thing. Our ventricular assist device patients, it's a whole different kind of classification, than our ECMO patients. But we've routinely used, the PD mag and things like that in small babies less than 10 kilos who are, for whatever reason, listed for transplant and awaiting and just hanging out on their VAD, and they seem to do fine. So I don't know if it's the VAD component versus the ECMO component or what causes it.
Yeah, and I would back that up. We've also used the PD mag on several smaller patients, and hemolysis does not tend to be too much of an issue for them.
Great, thank you.
It is a great question, though, and I think that's what's happening. We had issues before, well, this like 2014, 2015, with centrifugal, some of the early systems, and then we went back to roller. But now, as time goes on, I think that the production of roller is probably going to be less, and we're going to be forced to think about this, and it may be the new generation centrifugals are much better for the babies. I'm just curious, anybody from a pediatric heart program that's using centrifugal? Show of hands. So lots. Yeah. I guess I'm sort of an old dog. I do kind of like the roller where you set the flow. Like I'm such like, I like that control. But I think we're going to have to think about it. But it does seem like centers are starting to use it, and the new versions. Oh boy, here it is. So this is Jim. This is my boss. Oh boy, did I say something wrong?
No, I'm Jim Connolly. I'm from Children's in Philadelphia. Thank you for this talk. This is awesome. And I couldn't just sit in the back like I normally do and just listen.
That's good.
We're not, for me, there's a couple of issues that we have to deal with. It's not simply roller versus centrifugal. It's roller versus which centrifugal.
Yeah.
The roller pump is, and it's now becoming which roller pump, because now we're getting end-of-life letters for systems, so they need to be replaced. The centrifugal pumps from early development, to current development, are not just centrifugal pump. You can't just say centrifugal pump. You have to say which one. In fact, it even goes to the rotoflow, where it's just a question of the orientation of the head. The rotoflow head is in the cardiohelp, but instead of a single point of entry like a traditional rotoflow, it's got 4 points of entry because it sits sideways on the oxygenator. So that has been historically a better running centrifugal system, in my opinion, and we use it in our bigger patients, and we use it for transports in our smaller patients. The cardiac center in our place uses centrimags, and if they're on a centrimag, we stay that way. The other issue that we have to deal with, and it's probably worth a discussion, is the economics of this kind of support.
Yeah.
To use a cardiohelp is great. It costs $14,000 a circuit. To use a centrimag is great. It costs $8,000 a head. I can get a roller head circuit with an oxygenator for $2,500. So, the economics of the systems that we have to talk about are not simply just roller versus centrifugal. It's which ones, and which ones are going to work in your program. So, thoughts? I'd appreciate that. Thank you.
Yeah, I'm still I find that chilling, the end-of-life letter. Oh, that's right. I can't stop thinking about that. Any other comments? Oh, here we go. Oh, my God. I didn't look right. Sorry. My apologies. Dr. Harding?
Hey, that's all right. Matt Harding, Houston. I'm going to go back to the very first thing you put up there and ask the group a question, and maybe the audience a question, right? You showed PETA's data, which are beautiful. And in talking to those that participated in the development of that data, that was like yeoman's work, because it was initially, okay, hey, let's look at roller versus centrifugal. And then it was, okay, roller looks better, but maybe it's because people started using centrifugal and they didn't know how to use them, so let's scrap the first few patients. There was really a lot of thought that went into that analysis. It was a really good work. So we keep talking about hemolysis, but my question is, those data pretty nicely show, and I get that there's different types of centrifugal pumps or different things, and so we've got to be thinking about, we're talking about those data were mostly for not the PDMAG level kind of centrifugal pump. But if you're going to use a centrifugal pump against those data, whether it's hemolysis or some unknown factor, and the outcomes are worse, I'm wondering what the justification is. Why? Why use a centrifugal pump given those data as opposed to a roller pump? That's my question for those that are still in the centrifugal group.
All right, you're in the hot seat now. Okay.
Did you see that poster that was from ELSO that had updated information for VV with centrifugal versus roller? I don't know if you were on that, Matt. So I don't know if one of the authors of that poster is here, but that experience from ELSO, I think it was 5 years of data, showed there actually were, there was some more hemolysis with the centrifugal pumps, but they had less mechanical complications and some better outcomes with centrifugal versus roller. So, I think there's a lot to what you said about, I think as pump technology has evolved, and I do think the centrifugal pumps are, better now, and it, as was just mentioned, I think you have to say what pump you're talking about, and it's hard to lump them all together because, other systems I've used, I've seen tons of hemolysis, and With the system we're using now, there's some hemolysis, but it's not bad. It's very manageable. So I think it also gets down to your hospital having the same system. I think for competency of your specialists, you use one system, one pump. People know how to use it. They know how to respond in emergencies. I think there's some costs with that as well, maintaining just one type of pump. So I think those things also factor in.
Javier, any comments?
So a question for all of you. You have a 2-kilogram baby, CD8 baby, 34-weeker. Do you put it on centrifugal or you use a roller pump? VV ECMO or VA ECMO?
We would use a centrifugal and VA on a 2-kilo baby.
So that's a loaded question for us, since we don't put a lot of our CDHs on ECMO at University of Utah. And so again, I think we always are a VV preferred from that standpoint. Again, you'd have to assess the candidacy and appropriateness with the size of the patient from that standpoint. But we are centrifugal across the system, so I don't think we would make exceptions.
Yeah, I mean, we would do VA for that kind of a patient, but again, because our institution has not yet moved to centrifugals for those smaller kids, it would be a roller head pump for that one.
I'm similar. I'm old school in that manner. VA, and we do roller pumps for the little kids.
I would be impressed if our surgeons got a VV cannula and a 2-kilo baby,
Yeah.
but I would, yeah, we would do VA and centrifugal. Yep.
And if the same baby is septic now, because we had this problem for real, and with an enterococcus,
We would VA with a roller pump.
And we would still use VA and centrifugal because we're a centrifugal center.
Centrifugal, you don't have anything else.
Yeah, I was going to say, I don't know if you're going to get too many dramatic changes in our system level support as we go through from that end. I agree. I think you're going to lean towards the most support that you can give for that particular patient, which would be VA. But again, I don't think anyone is going to really be able to change the system for that patient.
Did you change what you did?
Well, really, we love rollers, like in North America. So it's not easy to change nursing, think. And with the new roller pumps, I think it's going to be much better. I'm worried about sometimes they come in South America, you don't get a roller pump easily. So you just can buy a centrifugal pump, and they are there everywhere. But there is not enough specialists or nursing staff that know how to use it. So that can be a problem, as you said. We don't know how to use it, maybe. Especially on low flows, when they increase and decrease suddenly in a 2.5-kilogram baby. So we feel more comfortable with the roller pumps.
I kind of want to flip it back to you and ask how many people would offer VA or ECMO support to a 2-kilo, 34-week CDH. Is that something ubiquitous across your programs?
Yeah, this is the wrong session.
Yeah.
We'll have to cut you off.
Go way
Sorry.
smaller.
All right, we'll move on to BiVal.
Yeah, I'm going to move on to BiVal. So I think, oh, one more question. Sure.
I'm also from Charleston, and we use roller in our kiddos that are less than 10 kilos, and then we use centrifugal in greater than 10 kilos. My question is, dealing with the hemolysis, do you find that anticoagulation strategies play a part into this? And so our peds cardiac ICU units, when we get our surgical kids, sometimes our surgeons don't want to start anticoagulation for 24, 48 hours, and we deal with clots and that type of thing. And so when you're on something like a cardio help, are you changing
Well, that is a great question, and that's like you're a plant, like to segue into the next section. So thank you so much, gold stars. Okay, and then did you have one question?
Time for one
yeah,
more?
of course.
Okay, so for centers that use the centrifugal pump, did you start doing the plasma-free like hemoglobin check after you switched, or were you always been checking it with the roller heads too?
Yeah, that's a great question, isn't it? Because it is, I mean, Jim can speak to that. That does, depending on your occlusion, you can definitely have an elevated plasma free with a roller system. Oh, here he comes. Oh, is he coming? Yeah. So you definitely can. Now, we don't follow it on the roller routinely unless we start to see the pink urine or creatinine going up or something. Then we do check, or the circuit's kind of dirty, or Jim will tell us what we actually do. Go ahead.
No, but the rest of the panel, I was just wondering, is this something that they started checking because they felt like that, centrifugal pump is going to do this, or you've always been checking
We
it?
do know centrifugal pumps are higher risk, right? So we did, most people, yeah.
I think most centrifugal centers, check it.
Yeah.
We still check it on our rollers at least, I think twice a day. I think it's Q12 or something like that.
Oh, really? No.
We don't check plasma-free hemoglobin any longer. The way we were taught, initially we were taught the Bartlett method from Michigan, and we used to do plasma-free hemoglobins every day, just a daily check. But I suppose we just got better at setting pump occlusions on a roller head because our plasma hemoglobins were negligible to 0. So the lab actually stopped offering plasma-free hemoglobin.
Yeah.
So we had to, when we started to redo it, we had to send it, next door to the University of Pennsylvania until the lab realized that the VAD program needed plasma-free hemoglobins, and they brought it back in-house. But, roller pumps have no plasma-free hemoglobin, so I'm also interested, and I forgot to mention when I jumped up here before, that, we used to be 0, and now we're looking at a number that we'll accept. So, as the technology gets better, these low numbers are essentially, 20, 30. That's really good. We didn't do any interventions clinically until it was over 100. So, and of course, looking at the baby.
Yeah. Thanks, Jim. I think we're back to, it feels like, where's Matt? Back to 2014, 2015, where we say, do what you do best, but yet we've got newer systems, so we have to have an open mind. And we've got these end-of-life letters, so we know we're not going to have rollers forever. So I think it's a good time to discuss this with colleagues, and figure out what's actually happening, and get some publications about complications, because the last publication we have, is negative. Okay, so now we're going to start to talk about bivalve. And it actually was Dr. Kays who spoke at this meeting. He spoke at Keystone several years ago and talked about use of bivalve in CDH patients on ECMO, so on newborns on ECMO. And he put this paper out, and it was quite controversial, and he got us all talking. Since then, many of us have converted, and so what we wanted to do was talk about what we're seeing. So I think I'll hand it over to Bob. Does that sound good?
So I think most people know, one of the benefits of bivalve theoretically is as a direct thrombin inhibitor. It works both on circulating clot as well as on clot that is bound to thrombin, and it doesn't require AT3 and has some other advantages compared to heparin. We had a poster on this, and this is also some data from just our group up here on the panel that we just kind of talked with each other about what you do with bivalve, and you can kind of look at those numbers as far as starting dose, what average dose you tend to kind of settle out on, how you monitor. I think most people use a PTT, some centers use a TAG. We're one center that uses, we actually get bivalve levels that's based on a dilute thrombin assay that our lab's able to do. So we follow that primarily, but still do a PTT and an RTAG to follow what we're doing with our bivalve. I think, again, we can talk more in questions, but anecdotally, the centers that use bivalve that have switched over, I do feel like Nick had mentioned that we get longer circuit life because of some of those properties of bivalve, have less blood product use, and maybe less problems with hemolysis. But again, a lot of this is anecdotal and is really kind of new. But there are a subset of centers that are certainly using bival in the neonatal population. So this was a poster we had that was based, again, on data from the CHNC. And again, this is survey data. We sent this out to, I think, about 27 centers that are within the Children's Hospital Consortium, and 22 responded. And you can see that there's kind of a wide range of experience with bival, but there are a couple centers that are using bival for all their neonates. There are a couple centers that are using it just for CDH. There's a larger number of centers that are using it when they run into problems related to heparin, as far as heparin resistance or HIT concerns. And then there's also a fair number of centers that don't use bival at all. The places that use bival, the majority of centers still load the patient with heparin. In Seattle, we actually give the patient a bival load, so we don't use any heparin. Our perfusionists also prime the circuit with bival. And there's kind of a mix of ways that people do that. One of the concerns with bival is low flow states, and one of the questions we also talked about was when you trial off and you're clamping off on VA. If you do that, there are a couple centers, including us, that also will give some heparin, a heparin bolus for trialing off, since we're at lower flow, to help with some of the concerns with clotting. We can kind of circle back to that, but that's some of the data from the CHNC. And did you want to talk, Nick, about your experience? Nick also.
Yeah, no good deed goes unpunished. And so my partner in crime, Carly Herond, who's our anticoagulation pharmacist, was going to be here, but unfortunately couldn't make it. So I got to, share the data that she's been collecting since we moved over for primary bival. So in March of 2021, we moved over into a primary algorithm. We have tailored dosing based off of risk of bleeding, as well as renal, coexisting renal injury or insult. And since that time, what we did is we went back and looked at over the 5 to 8 years prior that we were optimizing our heparin protocols versus moving on to bival. We wanted to see kind of are we doing with just as good of a job as we were before, right? And so the first answer, the primary outcome we really looked for was, are we within that time of therapeutic threshold, right? You want to know, is your anticoagulation meeting your PTT targets? Is it doing the things you're wanting to do? And the answer that we could say based off of our study, we did case matching 50 patients from that end, is that it's pretty equivocal. Within a year of a brand new protocol, our time in therapeutic threshold was 61.07 versus 61.13. So pretty spot on versus something that we've been working over 5 to 8 years to optimize with heparin. We were able to achieve that same there. So then we go back and ask, what complications are we having? What are the overall effects? And then the third part was actually cost, right? Again, going back to the answer, we can't put all kids on the most expensive therapies. We have to look at the cost utility. So complications-wise, within the small cohort of 50 patients, we were able to determine a significant difference in bleeding risk, large bleeding risk from that standpoint. And we were pretty close. If we would have actually increased our power from that standpoint, we had a trend of actually decreasing mortality, which is pretty impressive in the small cohort that we have. Again, this is retrospective. It was not a prospective randomized trial as we're going through. But we were very optimistic about what we were seeing from this early transition to bival. And then the third part, again, what we highlight in here is that the cost, when you take into account for the cost of AT3 as you go into it, the difference between bival versus heparin, we were saving money hand over fist comparatively from that end. And so the people who would argue bival is a lot more expensive, when you think about all the things regarding circuit longevity, AT3, we were able to demonstrate a demonstrable cost savings as we moved over into this protocol. And this is within a year of implementation. So.
So one of the things that I would say if you're thinking about implementing this, and I'll be very upfront and honest that I'm a huge bivalve proponent. In our center, we started using bivalve about 4 years ago for all comers. And in that time, we've had about 50 patients who've been 0 to 6 months who've been supported on bivalve. Now, when we were instituting this was going to be a big culture change. And I'm sure anybody who's been a part of doing any sort of culture shift, you know that there are two things that people hate in the world. One is change, and one is the way things are. So in the post-cardiac surgical population, one of the things that was a big concern for our group was, are you going to have an increased risk of bleeding? And that was, forefront on all of our surgeons' minds, on the intensivist. And so if if we were able to go back to that slide where you look at dosing and initial dosing, if you look at ours, and you're not bored by looking at slides at the end of a Friday, our dosing is significantly lower than most of what other places are doing. And what I can say is that I think that, again, it's anecdotal experience. We've had very good experience with bivalve, but I think we've taken a longer time to get therapeutic because we've started lower. And we did that so we didn't have, complications, having somebody immediately say, we can't do this anymore. We're going to change this. So I wouldn't take this and say, okay, you should start at 0.05 in a post-cardiac surgical, situation. If you look at the VADs, the post-surgical VAD patients, which are not exactly the same as a post-cardiac patient, but still post-cardiac surgery in some ways, they start at 0.3, unless there's concern for renal dysfunction. So I think we're going to be moving ours to 0.5, because if you look, we all end up at about the same dosing. It's just that we've taken a little bit longer. So if you're thinking about implementing it, I would just say that I wouldn't start as low as I did, because I think you may find that you're having more problems with the circuit that aren't necessarily secondary to the bivalve not working, but being subtherapeutic.
Yeah, that's great. Maybe John and Jessica can, because they've used bivalve a fair amount at both of their sites, can comment.
Yeah, we've been using it, exclusively, I would say, 95% of the time, for about the past 2.5 years. We initially, when we rolled it out very sparingly, and you had to have kind of a set criteria to go onto it of you weren't able to meet your ACT goals or your heparin levels, or you were having consistently increasing heparin levels, and then it kind of just morphed into everybody just wants to start on bivalve because we had a really good experience with it. The CDH population is, I think, really where we started to see the biggest benefit. Most of our CDHs go on ECMO. And get repaired within that first 12, 24, 36 hours. And, there's that lovely game of turning the heparin off, starting the Amicar, and then turning the Amicar off and starting the heparin back on and having bleeding. And that if they repair that kid during the day, you're going to be up all night. That circuit's going to be trashed. And, you're going to be debating, do you cut out a component? Do you change the whole circuit? What do you do? And then we found that when we were just turn our bivalve off, did our operation, turn the bivalve back on, the circuit life greatly improved. We had less bleeding complications with the patient. We actually were able to stop putting in chest tubes at the time of closure for a little while, which was really great. We've seen a lot less bleeding, and then it just kind of became everyone's kind of favorite agent. We were finding reasons to change from heparin to bivalve within the first day or two, almost all of the time, and then we finally have just said, well, we should fish or cut bait and make it official. And so we finally made it official. And we've been very pleased with it. Our circuit lifespan has increased. And to Nick's point about cost, that was the biggest thing that we had to go back to kind of our administrative group and say, hey, yes, this drug is more expensive. But when you look at all of the cost savings in terms of product utilization, component changes, circuit life, it really, antithrombin 3, we were spending $1 million on AT3 every, half a year or something like that, and we've been able to cut down on that significantly. So it's a big change for us, and it's been really great.
Yeah, in Arkansas, in the NICU, we use bivalve for the CDH population, and we partly started with them because of Dr. K's paper. That's the data that's out there. Also because nobody likes change, and so it took some convincing. But we have had the same experience that John and our surgeons are actually very happy. We're a center that repairs CDHs on ECMO, and they have all commented on the difference with bleeding in that population. We used to joke that we don't know what's wrong with our CDHs, but they chew through circuits. and we have seen that less. So now we're going to go the same road as John and transition all of our NICU population that's to bivalve.
Yeah, and just also in Seattle, our push really to convert to bivalve was from the surgeons, again with the CDH population, and I think we just decided to do it on all the neonates once we started. And I would say our experience is similar to John and Cheska as far as, you know, we also changed our protocol to operate, you know, within 24 hours, typically once they go on ECMO. And we've had a much better experience with bivalve versus heparin. We don't use Amicar anymore. We don't turn the bivalve all the way off, we turn it down. It's pretty similar what's in the K's paper as far as their protocol, and we've had good success with that. And we've done about 25 neonates now, I think, with bivalve, and have been pretty happy with that.
Bob, can I ask you a question? Natalie, can I ask Bob a question real quick?
Can you what?
Can I ask Bob a question?
Oh, sure, yeah. Sorry.
Sorry.
Where'd I go to medical school?
You said you load all of your patients when you're cannulating with bivalve. You know, we looked at that, and we kind of found that, at least in the pharmacy system we have now, it would delay our cannulation times. And, you know, it's easy to just have your heparin syringe sits there on the pump, you load the pump, and off you go. Did you guys have to modify your process of getting bivalve up to the patients so that you could load the patient in the circuit with it? Because ours has to come from central pharmacy, and, you know, there's X number of minutes, you know, to hours to get it ready. And so we were worried that we'd be delaying cannulations.
So for ECPR, we use heparin, but if it's not an ECPR situation, then we typically have time to prime with bivalve and then get a bivalve patient dose, just like with heparin. So it seems to come up quick enough for that.
Thank you. Okay, question?
Sorry, I got excited and then you put up your next slide. But my question is, do any centers who use bivalve routinely dialyze, and how does that affect your dosing and your strategy?
That's a good question.
We run quite a few of our kids in tandem, you know, on the PrismaFlex we use the HF1000 filter for our kids on ECMO, and we have actually, interestingly, seen an improvement in our CRT filter lifespan with using bivalve for these kids. It doesn't seem to affect, and we're running CVV HDF for all these kids. So, but we're not seeing a whole lot of dose adjustments that we're having to do when we dialyze these kids.
I would echo that. So if a patient's on CRT, we have them on bivalve, and it hasn't been too much of an issue, and there haven't been these wild fluctuations. You might have to make some adjustments, but it's not crazy. The only thing you have to remember is if the bivalve does get stopped for some reason, then you have to deal with the CRT.
Question.
I think Mark.
Yeah.
Oh, hey.
Mark Malter, Phoenix Children's. I have 3 questions now because of what you said.
You only get one question.
So, just questions. So I'll start with the dialysis question. So where are you running your bivalve then? Because I will say that we've only done bivalve so far in our cardiac patients, and maybe that's the problem. But we seem to have issues with our dialysis circuits going down all the time. And I mean, we've actually had a bigger problem than what we had on heparin with bivalve, and I guess maybe we're doing something wrong with that, but I'm just curious how you do that. And then in the same lines of that is, how are you dealing with, or in your circuits, do you have access points? Like, do you have pigtails or other things that are in there, and what do you do? How is bivalve working with those stasis points that go along with that? And then the third question in there is, you've talked about changing your circuits quite a bit. What do you mean by what is your definition of a trash circuit, or what is the end of circuit life that makes you then change it along the way? Because I'm listening to you guys talk about that, and I just find that we aren't actually doing that many circuit changes compared to what you're describing or that. So thank you.
All right, so who volunteers?
I guess I've been.
He's the one that said the trash circuit.
I guess I've been volunteered.
He gets to start first.
You know, the short answer is when my ECMO staff tells me that I need to change the circuit. But in actual fact, I think we consider it, a circuit that needs to be changed. If we're having a lot of platelet consumption, if we're having to give a lot of product, if we're unable to reach our anticoagulation goals, if we have quite a bit of visible clot at various points in the circuit, or if our transmembrane pressures start to go up across our oxygenator. Those kind of are the objective pieces of data that we look at. Also, you know, if we're talking about having to come off for a second, rotor-rooter a cannula, suck clots out, things like that, you know, then we'll consider just, okay, let's just change the circuit. I will say we do quite a few less, so I'm not having to make that decision as much anymore, which is nice.
Well, since you talked about the rotor-rooting of the cannulas, because that was a big point of contention with our surgeons when we went to bivalve, because on the case paper, they talked about having to essentially go and fish out clots. And what we found is that we needed a higher dose of bivalve. We have not had, than was in his paper, we have not had the bleeding, but we also have not had, the surgeons had to go back on and clean out the cannulas. As far as when to change the circuit, I have to echo what John says. I mean, look at the patient, look at the circuit, but oftentimes rely on the ECMO specialist and coordinator.
Well,
I mean, we try and give as many medications as possible to the patient and limit the amount of access to the circuit, both for the connectors being an area of clot, whether you're using bivalve or heparin, and also just to get away from people accessing it every time you do. Obviously, there's a chance for a complication there or air entrainment or something. And so it's been a gradual culture shift to move people away from thinking of the ECMO circuit as sort of a giant IV, and really making sure that we have central access for our patients.
And I do want Kate to address one thing that you said in our pre-work, our pre-planning, was that concern about stasis. And we do hear that a lot. People are quite worried, especially with cardiac dysfunction. Would we develop intracardiac thrombus? And we talked about that. And Kate's in the cardiac unit, and you said.
Yeah, so that comes up a lot. So we'll have patients who either have myocarditis or have post-cardiotomy, the stun, and they come in and their LV's at a total standstill, the aortic valve isn't opening. And it's something that we talk about a lot, and sometimes you can see on echo, you see some kind of swirling there, you see something, and everybody says, oh, it's a clot, they're on bivalve, we have to stop it, we have to move on. And then you get an echo, 6 hours later, and either it's not there, it's not changed, or something's a little bit different. And I'm not going to say that we haven't switched from bivalve to heparin in some of those instances, but in many of those instances, even if the kid is at total cardiac standstill, we haven't seen thrombus. And even it doesn't take a ton of flow to make sure that you're not clotting off your circuit with the bivalve. So I'm not saying don't look out for it, and it can happen, but it's not something that I certainly would think, particularly if it's something where after cardiac surgery within 24 or 48 hours, you should be able to have pulsatility again. I wouldn't necessarily jump to saying, okay, we have to stop bivalve.
And I think just the circuit in general, how your circuit's constructed, and having, if you have a lot of connections, and the less is probably better, and at least our circuit is pretty streamlined with the cardio help, so I think that's partly why bivalve does work pretty well for us. And we're also like Kate, we try to give as much as possible to the patient and don't access the circuit very much.
Okay, one last question would be great.
Yes. In my hospital, we use 100% bivalve for CICU and the PICU. But newborns, only currently the patient is resistant to heparin, and I want to switch 100%, but not yet. So the risk of thrombosis with stasis, question mark, but it is definitely yes. So the pigtail has more clots than using heparin. And I did a very quick experiment. I measured bivalve level by dilute thrombin time method, and the specimen is not spun down for 1 hour, 2 hours, 3 hours, 4 hours. So up to 2 hours, it's stable. But after that, bivalve level significantly goes down. Oh. So it's the indirect evidence of the stasis degrades bivalve.
Thanks so much for your comments, and thanks everybody for coming to our session. Oh no, one more. Rachel, okay. I know we're over, but we're having so much fun. Sorry, okay, Rachel, go ahead.
I was just going to say that we used bivalve for like 3 to 4 months throughout our whole program, and a couple of things. One is I think we had a very similar experience to Stanford in that our CT surgeons were very nervous about bleeding, and so we started really low, and so it took us a long time to get up. But the other big thing is we routinely use CVVH, and we were changing circuits constantly because I think of the same thing, the stasis, so smaller connections, et cetera. And so we eventually moved on, but we haven't completely eliminated the thought of it, but I do think where you start probably makes a big difference.
In terms of dose.
In terms of dose, in terms of not having a long period of time where you're potentially going to be below adequate.
Yeah. All right. Thanks so much for those comments. So thanks everyone for joining us for this session. It was great to have you here with us. And thanks so much to the panel. All right, have a good evening.